So these are the topics that we'll touch upon here in the next 10 minutes or so: bracing, reduction of radiation, 3D imaging. We will go over this quickly because Keith did such a nice job. Preoperative planning, intraoperative imaging, growth modulation techniques, infection prevention, and protocol-based. So one of the big events in spinal deformity surgery in the last couple of years, in the last several decades, is the final publication of this BrAIST study. The BrAIST study was a multi-center study looking to try and answer the question, does bracing work? And the answer was a resounding yes. Prior to this study led by Stuart Weinstein in Iowa, there were some very good people, and I think all of us at some level didn't really know how good bracing was. But the results of this study showed that it not only is effective, but that there's a dose response curve. In other words, the more you wear the brace, the more likely the brace is to help. And the data, the results were so strong that our governing NIH pulled the plug on the study, had to stop the study for ethical reasons, because it was felt that continuing with the control arm of no bracing was unethical for those patients. So this was a very important event and is helpful in the discussion of screening, but especially in the discussion with our patients and their families, that they, if they're growing and their curve is under 40 degrees, the brace is their only chance of avoiding surgery if they're a high-risk patient. Here's a picture of Stu Weinstein delivering this paper. It was in Lyon at the SRS meeting a year and a half ago. To move quickly, the next is a very concerted effort to decrease the amount of radiation that our patients get. Many of these are young girls who will become women, and many of the young women in our world will develop breast cancer and other forms of cancer. So there's a very specific effort underway to reduce the amount of bracing. There are several studies that show that patients with scoliosis in general get a lot of radiation. This study shows that patients who have operations even receive much, much more radiation. This is a study from JAMA Pediatrics several years ago, just trying to translate the amount of radiation that our patients receive into the risk of them developing different types of cancers. And there's a fairly compelling argument here that yes, indeed, this is a lot of radiation, and these patients will be at risk of having radiation-induced neoplastic problems in the future. So as a result of that, there are different techniques. The EOS machine is one tool that not only helps in the 3D classification of the scoliosis, but the amount of radiation that the patients receive is said to be 1/8 of a traditional PA and standing radiograph. So it's the big advantage to this new advanced imaging, I think, is not so much the research benefits, but the reduced radiation to the patient. I'm not going to spend much time on this. Keith did an excellent job talking about the 3D classification, and this is a spin-off of the EOS and these other new advanced imaging techniques. One is able to achieve very beautiful three-dimensional imaging of the spine, and you can calculate rotation and the other many parameters that Keith and George nicely described in their paper. And this has led to the development of this axial Hubert-Lebel driven 3D classification, and also allows us to incorporate pelvic parameters, what's happening to the pelvic incidence, the pelvic tilt, and this is all very important, especially when the patients become elderly individuals, and trying to preserve the remaining lumbar unfused disc that we work so hard to preserve. So that's all I'll say about that, but it's an exciting time to see techniques developing to try and decrease radiation for our patients, especially young children, early onset patients. The preoperative planning for the treatment of severe curve, severe deformity is not AIS, and there's efforts underway to minimize blood loss, to protect the pulmonary situation, and to avoid prolonged postoperative recovery and complications associated with these big surgeries. And we know severe deformity is associated with a significant incidence of infection. This study shows that patients with neuromuscular scoliosis in a multi-center well-run study. It's almost 10% deep infection rates. I think that may even be an underestimate for incontinent neuromuscular patients, and then syndromic and congenital scoliosis patients also has shown almost 9% for syndromic and about 4% for congenital. So it's a huge problem, and it's something that lots of us are working hard to try and reduce to a never event, which may be unattainable but is a worthy goal. Trying to reduce bleeding is very important. There have been lots of efforts. George Thompson has probably been the single individual that's done the most work on this. And there are several agents used. Amicar is this EACA is Amicar, tranexamic acid, and then protein are really the three agents that are used. And to cut to the chase here, the Amicar is the least expensive and probably the most effective, available, inexpensive treatment. And I'm going to defer to George on an additional discussion, but these agents do work. There's lots of interest in reduction of bleeding. Another, in the United States, a paper that came out from the American College of Surgeons that gained a lot of attention, provoked a lot of discussion, was this paper ranking designated pediatric centers. And to summarize this briefly, the final conclusion was that this paper ranked into level 1, level 2, and level 3 centers based on the staffing and secondary resources and specialists and intensive care capabilities. And I think this has initiated a discussion in the United States, at least, that big, risky, expensive surgeries will likely in the future be shunted to the level 1 centers. We're beginning to see this happen. There are payer implications associated with this likely in the next decade with Obamacare, accountable care in the United States. This will become a reality and will likely play out in other parts of the world in the following decades. Preoperative planning, to shift gears again, there's a test called thromboelastography, which has been used in the cardiac world for a decade or so. Is simply stated, it's an early warning system that your platelets are dysfunctional, and for high risk, big blood loss, complex surgeries. This is becoming a test that many of us are doing as an early warning system that you may be getting into an impending coagulopathy situation. The reduction of surgical site infection, again, there's the use of these chlorhexidine wipes. Preoperative preparation has become important. There's 7 randomized controlled studies with over 10,000 patients. No clear evidence of the benefits of preoperative showering or bathing with chlorhexidine over other products, so there's conflicting evidence on this, but it has become the standard of care to try and reduce surgical site infection. Another area of intense scrutiny is whether the patient or the surgical team is MRSA or Staph aureus carrying individual. Another 9 randomized control studies showing if you have a patient who is a Staph aureus carrier, the use of this mupirocin ointment results in a statistically significant reduction of Staph aureus surgical site infection, and this is something that's emerging as a routine at most major centers doing scoliosis surgery. Another interesting discussion as an emerging trend in spinal deformity surgery is the use of 2 attending surgeons rather than an attending surgeon and a resident. And there's data shown in this graph in your lower right that if you have 2 experienced, well-trained attending surgeons doing complex major spinal deformity, you're going to have much fewer complications and resources used as compared to an attending and a resident. And this has become reality at several centers in North America and makes intuitive sense, but may be an emerging trend in the next decade. Intraoperative imaging, this is a reality, the use of the O-arm in this case to assess screw placement. Most of us will place the screws freehand and then assess the screw placement with O-arm spins to make sure that when our patient leaves the operating room that the screws are safely placed. And I think that's becoming a reality in many centers as an emerging trend in spinal deformity surgery. Growth modulation, there's a separate lecture later today about this, but I think the reality here is that there is a trend towards growth preservation, trying to do less destructive ablative surgery. And one area is with growing rods, and we now have this magnetically controlled growing rod that can be lengthened with an external spinning magnet device. This has been approved by the FDA. It's being used widely now in many centers. Here's a case of Hilali Nordin, the first magnetic growing rod graduate. And I think the Hong Kong group and Hilali in London have the largest early experience with this, and it probably is ready for prime time. We've done now a couple of cases. This is one of my colleagues' cases at my institution, and it seems like it's something that will be here to stay. And there are benefits with reduced radiation as a result of that also. So what can we avoid doing a fusion? What is missing? I think this is an area where there's going to be a lot of future. If you talk to industry, this is an area that they're very interested in doing more. Anterior approaches, osteotomy to try and gain additional correction is an area that's also gaining interest. And I'm just going to move through this for the sake of time. Infection reduction, I think many of us are using powdered antibiotics, vancomycin routinely, and also gentamicin powder for neuromuscular patients. And the first question in the pediatric world is the use of these powders safe for the patient from a systemic standpoint. And there is data to show that it is safe, and it is more importantly and secondarily effective in reducing infection risk in these patients. So I think most centers who are doing high volumes of spinal deformity surgery are using vancomycin powder to reduce infection, and gentamicin powder in the surgical wound for neuromuscular incontinent patients. And there are best practice guidelines. This was a Delphi-driven approach to develop consensus as to what are the important data-driven steps to reduce infection. This has been published. Mike Vitale led this effort, and I think is helpful as a checklist in trying to reduce infection. Predefined care pathways, protocol-driven approaches for reducing complications in high-risk spinal deformity. There's the PROMISE and the NSQIP in North America, which are efforts to evaluate the patients preoperatively. Psychosocially is the PROMISE group, and know what psychosocial factors may be pre-existing and may influence the surgery and recovery from the surgery. NSQIP is an effort to define the risk of surgery. We know spinal deformity surgery is very, very risky and expensive, and we need to have a risk adjustment tool to define beforehand for the patients and families, for society, for payers, as to how risky and expensive it will be, and that is playing out. So in summary, there are many different emerging trends. Much of this is technology related, and I know we all have different resources available to us. This may be a little bit of a snapshot as to what the future holds in your country, but I think the focus is a good focus. There's never been a better time to practice medicine and to do spinal deformity surgery, because the focus is on making it safe and effective and reducing the cost to society and our patients. So thank you very much for your attention.